One of the biggest surprises a lot of patients have when they come to see me is how little I actually give them to do after we go through our assessment phase and in the first appointment, in a lot of conversations during the first appointment. Sometimes it may only be one or two exercises that we work on at the gym or that I have them go do when they're not here with me. Rarely do I get to more than 3 things to go do, because otherwise they're just going to be adding stuff or forgetting things, and just adding things that aren't getting us towards our goal. And sometimes people they get a little bit like leery or upset and will look at me and say things like, "That's it? That's all I have to do?" Because they're expecting pages and pages of exercises and resistance bands and balancing drills and mobility routines that take their whole morning, 20 different things to keep them busy. And instead, I'm just like, hey, let's just focus on doing this one thing or 2 things. And then I tell them, you just need to trust me, right? And here's the problem. Many times, and it's probably a function of the internet and social media, people have been conditioned to believe that more treatment must mean that it's better treatment. That the more exercises you give them, it must be better. The more appointments that they have must be better. The more gadgets that I'm using means that it's better. The more techniques that I know and the more complexity I layer on top of what I'm wanting them to do just means that it's better, right? But biology doesn't care how complicated the rehab program is. Your body is going to respond to the appropriate stimulus and time. So there was this randomized controlled trial 10 years ago, 10 years ago, and they were looking at rotator cuff tendinopathies. And one of the groups in the study was just given traditional physical therapy as it stood at that time. Lots of exercises, lots of manual therapies, a lot of different techniques being used, some progressions. Then the other group was educated on the situation and essentially given one exercise to do over time. And there was some adjustments to that exercise as symptoms progressed. So the outcome is, in the end, they both had the same amounts of improvements. At 3 months, at 6 months, a year or more later, essentially both groups had the same improvements in their symptoms and the same decreases in their disability scores around their shoulder. So one of the big conclusions from this paper was something that I wish every clinician would sit back and think about for a while. Clinicians will consistently overestimate the value of adding more interventions to the situation. And I hope that makes you uncomfortable. And it makes people uncomfortable because it's true. Complexity is not the goal. I don't spend my day trying to impress a patient with how many exercises I know. I know a lot of exercises. I've been training for a long time. The hard part is figuring out which 1, 2, maybe 3 exercises are going to matter right now. And sometimes especially new clinicians, I see confusing doing more with accomplishing more. And those are not the same thing. When we're adding another exercise, it can feel productive in the moment. It can feel productive to you. It can feel productive to the patient. And giving another treatment might feel productive. Scheduling more visits might feel productive. But the question is always going to be, did it meaningfully improve the outcome that we were looking for? The question isn't, did it make me feel like I was doing something with the patient? That's not what we want. So when I'm evaluating someone, I'm not chasing novelty at all. I'm looking for the minimum effective dose I need to give this person to start moving in the right direction. The smallest possible intervention we need to change the trajectory of their injury at the moment. Sometimes that's one exercise. Sometimes it's 3 exercises. Sometimes it's just a conversation. Sometimes it's simply being, or sometimes it's simply just helping them understand that they're not broken right now. And the adaptation is what I'm after, not, a novel stimulus. I'm after the adaptation, and I'm after the exercise that's going to give us that adaptation. The exercise is just the stimulus. So don't misunderstand me, though, because there are some people that are going to need some ongoing care. Some folks just are not going to, and if you've worked long enough, there's a lot of people you work with that just aren't going to do anything without that accountability of having an appointment with you. Sometimes they need that in-person progressions. Sometimes they're going to just need a little bit of reassurance here and there that their symptoms are going to fluctuate and that we're still on the right path. And some people just need somebody to sit with every week and start and readjust their plan. And that's fine. That's valuable. That's, it's different. And those other visits are not valuable because they're full of novel exercises. They're valuable because the time is full of clinical reasoning. And the number of visits should reflect the needs of the person you're working with, not the habits of the clinician. So people will ask me this kind of question: what exactly are you doing when you're working with a patient? And honestly, most of my job is just helping the person trust themselves again. That's it. Sometimes that can happen in one visit. Sometimes it might take 6 months. Sometimes it will take repeated conversations that cover the same topic, but just in different ways. Sometimes it just takes me standing there without saying anything while I'm watching them move and trying to evaluate where they're at. And I am somebody who, in the rehab session, is comfortable with it being silent while they're working. So I don't need to feel like I have to fill every minute with another exercise for the patient just to prove that I'm working with them. I don't measure success by how many visits a patient has had with me. I don't measure successes by how many exercises I gave them to do. I measure success by whether they leave believing that they're going to be capable again. Because once somebody starts to trust what their body can do, then everything else starts to become easier. The best programs in rehabilitation aren't the ones that have the most exercises to them. It's the one that the patient will still be doing 3 months from now. And what you don't want to do is overwhelm people. The goal is to just help them start making the right adaptations. So sometimes less is more, and not because less is magical, because enough is enough. So my job isn't to make people dependent on me. My job is to help them trust themselves again.